Well, thanks again for coming. And with that, let's get going. So again, think about how you guys are going to use the language that we talk about today to teach others, to teach your relatives, to teach babysitters, to teach others who might take care of your child. One analogy I like to use is that of Superman. So Superman is healthy. He's super strong. And like kids, he's seemingly unstoppable and he's faster than a speeding bullet. And like teenagers, he's a snappy dresser and he thinks he's invincible. And like kids with food allergies, something that is seemingly harmless to others can make him feel sick really fast. And so this is my Superman. This is Scott. He's now 22. And we discovered that he had a food allergy when he was eating a chocolate bar with walnuts in it. He said it was delicious. It was so cute. Then about 30 seconds later, he told us that he couldn't get the taste out. Then he started getting irritable and cranky about 2 to 3 minutes later. I turned to my wife and I said, "Pam, I think he's having an allergic reaction." And she told me to shut up because I was such an allergist. I was a second-year fellow at Children's doing my allergy fellowship at this time. About 10 minutes later, he started getting really nauseous. Puked in the fish department of Whole Foods. They hated that. Then 20 minutes later, he started sneezing. Then he had itchiness in his ears. Then about 25 minutes later, he started having throat clearing. And then 30 minutes later, he had hives. Then my wife turned to me and said, "Mike, I think he's having an allergic reaction." So what was that? That was anaphylaxis. That was a severe, a serious, potentially life-threatening allergic reaction. And for me, that was my first time being dad of a child with food allergy. And so firsthand, I experienced the critical roles that we all need to play. And so we are, you are, I am coordinators. We work with physicians, schools, secondary care providers like grandmas and aunts and uncles and babysitters, and coaches when the kids get bigger. We support kids in a developmentally appropriate level. We're advocates. We need to ensure that the child's health and self-esteem are taken care of in whatever setting they're in. We're role models. We're going to want to be role models for our kids and, more challengingly, the community at large. And we're educators. We're going to need to teach our kids. We're going to teach secondary caregivers and the surrounding community about food allergy reaction prevention and emergency preparedness. So the goals of this talk and our time together now is to help you address the uncertainty and the fear and replace it with facts and empowerment, and then also support your roles as coordinators, advocates, role models, and educators. So let's start with the nuts and the bolts. So I was mentioning before, the type of food allergy we're talking here is IgE-mediated food allergy, immunoglobulin E. It's an abnormal immune response to food protein. We use our immune system to fight germs like viruses and bacteria. In the case of a food allergy, then it kind of, in a sense, overreacts, and we attack something that's seemingly harmless to other people, food. So in the case of a peanut allergy, the peanut protein here, if someone consumes it or comes in contact with peanut, then this is supposed to be a representation of an allergy cell. Mast cells and basophils are the ones that I'll be talking about mostly. Now, if you then have the peanut protein, it binds on this IgE, then that can make the mast cell or the basophil release what's inside, causing the signs and symptoms of an allergic reaction. The most common allergens, there are 9 most common allergens. Now, people can be allergic to practically anything. So any IgE-mediated food allergy should be taken care of the same way. And your primary care clinicians, your allergy teams, they'll teach you guys how to manage that. So, by the way, anything you learned from me, check in with your actual clinician first before changing any management. This is just general education, unless, of course, you're my family. All right, so signs and symptoms of allergic reactions can vary from kid to kid and even from reaction to reaction. So one child doesn't necessarily have the same reaction another child does, and one reaction isn't going to be identical in the same child the next time. And so Symptoms of allergic reactions can include of the skin system, and these symptoms within the system, hives, swelling, itching, warmth, redness. It can also be of the respiratory system, and the symptoms within that can be coughing, wheezing, shortness of breath, chest pain or tightness, throat tightness, trouble swallowing, hoarse voice, nasal congestion, hay fever-like symptoms like sneezy or runny nose or itchy nose, red, itchy, watery eyes. Now, in the case of a young child who can't communicate what they're feeling, we might see a young baby scratch at their ears for skin. They can't tell us that they're itchy. We might see them scratching at their tongue, raking at their tongue. For respiratory system, they're not going to tell us that they're short of breath. We might see them increased work of breathing. We might see tugging in their ribs. We might see tugging above their sternum. We might see nasal flaring. We might hear coughing. We might hear wheezing. For GI, nausea, stomach pain, cramps, vomiting, diarrhea, and the little ones, vomiting is fairly common. We also can see diarrhea. We can also see kids bring up their knees to chest or back arch. Cardiovascular system, bigger kids can explain dizziness, lightheadedness. We can see people be pale, cool, blue cyanosis, gray color. Weak pulse or fast heartbeat is something that doctors would be able to tell. Fainting, shock, loss of consciousness. And little kids, we could see sudden behavioral changes. We could see limp, very lethargic, and neurological anxiety, feeling of impending doom in an older kid. And as I was saying, mental status changes in a younger one. And women can experience uterine cramps as well. So again, varied symptoms. It's not going to be necessarily all of them, and it can be in multiple systems. And being able to pattern recognize is going to be very helpful. The majority of allergic reactions occur within minutes to a few hours later. Anaphylaxis is a severe, potentially life-threatening allergic reaction, and some people have no skin symptoms. About 80% of the time in anaphylaxis, we're going to see skin symptoms, but teaching other caregivers that it's not only dependent on the skin is going to be an important tip. And anaphylaxis can start with only mild symptoms, but then it could progress and then start including other systems. And epinephrine is the first line treatment of anaphylaxis. It works quickly, it is safe, and it shuts the reactions down. In older kids, food allergies can have impact on emotional and social aspects, and it can decrease kids' participation in sports and other activities and impact families, for example, travel and going out to restaurants. So being able to implement some of the management strategies that we'll be talking about today can help you do these things. Now, it's a balance to be able to take appropriate strategies to prevent accidental exposures and have emergency preparedness, while at the same time having full quality of life. And so we want to strike that balance between worried thoughts and then risk taking. And in teenagers, it's really important to train them as they age to get there. So now I'd like to take what seems like a pretty complicated process and simplify it into basic food allergy management strategies, the two pillars, the pillars of avoidance and emergency preparedness. And these you'll want to think about. You'll want to be able to implement in all situations and all circumstances, whoever is in charge of the kid and wherever you guys are, or wherever your child is. So we're going to want to implement it at home, in preschool or school or daycare. When we go out to eat in restaurants, drop off parties, drop off play dates, parties, play dates, and then also secondary caregivers like grandparents. So let's start with prevention. We'll want to act to prevent accidental exposures. Avoid, communicate, and teach. So there are different ways that we could come in contact with food. The most important is through the mouth. That is going to be the cause of the majority of the more serious allergic reactions. Other ways to come in contact are by breathing it in, touching the skin, in the nose, and in the eyes. Oral ingestion, as I said, is the most important to be thinking about. It can take a small quantity of food. This is where many allergists or primary care clinicians will recommend strict avoidance, reading labels to avoid. Now, your allergist may have different recommendations based on the particular food or based on the particular child. And so you'll need to talk to them about what you do about label reading. And as I was mentioning earlier, in some of the cases, for example, with some kids with egg allergy, they are allowed to eat baked in egg. So clearly, this recommendation is going to be different based on the particular food and based on the particular kid and allergist. So reading labels is key. Each label on the food package should be read before that food is served to the child. Even if you bought that particular brand in the past, it's always worth looking at the new box before you open it and serve it, because there can be changes and there's no regulation that they need to make notifications of that. All caregivers serving and preparing food for your child should be aware of labeling laws and their limitations. So the Consumer Protection Act now has been updated to include 9 major allergens: milk, egg, peanut, tree nut, wheat, soy, fish, crustacean, shellfish, and sesame. This accounts for more than 90% of the foods that people are allergic to. Now, what it says is that they must be listed in clear, understandable language on food labels for all domestic and imported packaged foods. Any of these major 9 allergens has to be stated, even if it's just tucked away in flavorings, colorings, or additives. Where if it's not one of the major 9, they can say flavorings, colorings, and they don't necessarily need to disclose what it is. So foods that don't require this FDA regulation are meats, poultry, certain egg products, most alcoholic beverages. So certain meats, when the meat is the biggest weight of the product that you're buying, then that can technically fall under USDA, which doesn't have to follow FDA labeling. And so that's just a tip to be thinking about. Now, any other foods that aren't the major 9, such as other seeds other than sesame, molluscan shellfish like oysters, clams, mussels, scallops, and others, and other forms of gluten like barley, rye, and oat, these can be tucked away in wastebasket terminology, while wheat has to be disclosed and sesame has to be disclosed and crustacean shellfish have to be disclosed. So foods not in the major 9 may be hidden in flavorings, colorings, or other additives. So labels can be one of 2 ways. So it is according to guidance that it can just be put in the label itself without a calling. So in the case here of milk, it says milk in plain language, but notice that it's not really bolded. It's not sticking out here for us. Peanuts right there, same. So this is fine. This labeling is appropriate. The other way that a company can choose to disclose is by choosing to put a contain statement. They don't have to put a contain statement, but when they choose to put a contain statement, then they're supposed to follow up with the major 9 allergens. So when you train others to read labels for your child, train them both ways. Because some people, it's counterintuitive that there's more than one way. And if they see this and there's no contain statement, they may think that it doesn't have allergens in it. But always train them to go back and actually read the body if they're going to include it. So you can use this contain statement to quickly exclude an item. If it says soy and the child is allergic to soy, then it's easy to say, okay, you could stop reading, don't give it to the kid. But in the case of peanut, where we see this, we may just want to train them to go back and read the body and make sure it doesn't say peanut in there, just to be careful. So advisory labeling. The statements may contain produced in a facility. They've done some studies looking at the meaning of that. And one in particular was looking at peanut products. And 7% of items or of the products that were tested when they were labeled with one of these cautionary statements for peanut had detectable peanut. But in some of the cases, it wasn't high enough to be a threshold to cause an allergic reaction, while in some cases it was. When then they looked at the different particular terms, they didn't find that there was any association that you could make between what it said. So for example, when it said may contain, that actually didn't have values as high as when it said produced in a facility. And so the word choices specifically were meaningless, but the take-home point here is if you want to be conservative, if there is a cautionary statement, then exclude. Now, I usually make the recommendation in the patients that I take care of, especially in the younger ones, where I'm trying to work with the families to decrease small willy-nilly exposures, because not only might that decrease the chance that they have a reaction, but theoretically, it may also improve the chance that they might decrease their sensitization. And so you'll work with your allergist to decide whether or not you include cautionary statements. And here's an example over here where this says produced in a facility. Hidden ingredients are not an obvious component of a food. Often, the consumer doesn't know they're eating it, but the person who made the cookie or baked the product does. And so reading labels is really the only way to tell. Like, for example, a cookie, a muffin, some sort of baked product. Some common places where dairy can be hidden are in breads. In a restaurant, sometimes people butter steak, caramel, deli meat, hot dogs, cheese alternatives, canned tuna can even have casein in it. Guacamole can have dairy added, and non-dairy creamer can have dairy. It's kind of counterintuitive, but the take-home point is read the label, because otherwise it's hard to know. Peanuts and tree nuts can sneak in assorted desserts, Asian food, cross contact with seeds and other nuts, packaged popcorn, ice cream. It could be used as the glue on egg rolls, in sauces, pesto, Mexican food, barbecue sauce. Read the label. Egg can be used in baked goods. Again, egg alternatives, broth on drinks, the shiny glaze on the pretzel, pastas, ice cream. Label reading is the only way to know. Soy can sneak in various foods. Again, label reading is going to be super important. Same with wheat. And even fish and shellfish could sneak in there too. So take-home point's going to be always teach folks to read the label. Now, non-edible items can have food sources as well. And so some finger paints have in the past had dairy or egg whites, shaving cream, dairy. Paste can have wheat. Pet food can have anything that the pet is eating. Play-Doh has wheat in it. Old school bean bags and furniture used to have nuts. Birdseed, nuts and seeds, and food-related activities, if they're doing them in school, are going to have whatever food they choose to do. So these are all potential sources of cross-contact. So inhalation is the other route of exposure that I was mentioning. Now, luckily, it's rare. So reactions with inhalation can occur with active cooking, something that's going to aerosolize and bring up the food proteins into the air. That smell that we smell when somebody has a Snickers bar or has a peanut product, that's caused by something called a volatile organic compound. That's not a protein. And the majority of allergic reactions are caused by proteins. So just smelling it lets you know that it's there. But that smell itself isn't going to be enough to hurt somebody and cause an allergic reaction. But now if somebody were to pulverize peanuts and blow the dust in someone's face, and then you were to inhale the protein, that can cause allergic reactions. And that can be akin to being really allergic to something like a cat and going in someone's home. Those are going to be the things to be thinking about. So luckily, these types of exposures can be avoided. My clicker has stopped working for a moment. Any questions so far? Yeah.
If there's no cautionary statement, so like producing a facility with blah, blah, is it safe to assume then that it's safe?
Well, so this has been something that has been some debate in the food allergy community. Now, we can keep talking about it later, but for the most part, I've been recommending that in the cases of particular foods, like for example, ice cream, if you know that a brand does peanuts in one of the flavors and there is no label on a very similar flavor, then there actually may be some reason to think about, do I want to call a company and see in those particular cases? But for the most part, I'm not recommending to the families I take care of that they're calling everybody when you don't see one. But something in the case of like ice cream or chocolate has very commonly had cross contact with dairy in it. And so something like chocolate might be something worth asking unless they specifically say there's no dairy in it. So these would be specific examples to work through with your allergist, but for the most part, including those other than the highest risk ones would be something that most people do without any problem. And so now skin is another way to come in contact with food. Now, skin does a good job keeping allergen out. And so there have been some studies where they take peanut, they pick on peanut for many of the studies that they do, and then they extrapolate the data to other foods too. But in the cases of the two that I'm thinking of, they put peanut on the skin of people with past strong reactions to peanut when they ate it. And what they found was about 30 to 40% of those people had local rash and hives, but nobody had a full body allergic reaction. So that's really reassuring. But now a kid between the age of 1 and 2 put their hands or an object in their mouth 80 times an hour. And a kid between the age of 2 and 5 and hands or an object in their mouth 40 times an hour. And grown-ups in a library put their fingers in their eyes, mouth, their nose 15 times an hour. So a oral exposure can be pretty easy. So this is going to be where, while skin does a good job keeping it out on healthy skin, then it can easily turn into an oral exposure in a kid who's exploring their environment with their hands. Cross contact is the presence of unintended food allergen. If someone, and let's say, has a dairy allergy and we cut the provolone on the deli slicer and then somebody gets the roast beef afterwards, then they can have dairy cross contact. You can't really clean that very well. So that's where thinking about some of the things and the sources of cross contact are important. You're going to want to be able to clean with soap and water in between uses. So in the things where you can't, it's going to make it harder. So being choosy in what you choose to get served from, like deep fryers, even though you have extreme heat in there, that heat isn't going to denature an allergen and make it less allergic. But everything that was cooked in the day is now sitting within that. And so these are things to think about. Also, buffets where those spoons are going from one thing to the next, those are potential sources. So trying to, if there is something and you know it is safe, talking to the restaurant or the cook to make sure that there has been some source that hasn't come out to be cross-contacted will be helpful. Also, things like oven mitts, aprons, cans, these are all potential sources of cross-contact. Garnishings, if I have allergen on my hands, I put it in the salt and then I double dip and I come back, then I'm possibly bringing allergen into the food. Also sanitizing dip buckets. If I were to take knives with peanut butter on them and just chuck them in the dip bucket, then the particulates could get on the things that are in there, because again, it desiccates and dries, but it doesn't necessarily get rid of allergen. High chairs, car seats, you want to clean these before you set your kid down in them. If someone was sitting in them eating food, tabletops, hands, utensils, dishware, cups, water bottles, cutting boards and prep surfaces. And also think about sponges and reusable dish rags. If you clear away the sesame tahini using a sponge and then you clean your kid's sippy cup, then you're possibly moving allergen to that. So using something disposable, and the dishwasher works great. Saliva can also be a source of cross contact. So they've done studies, again, picking on peanut, where people ate peanut products, and then they tested their salivary levels of peanut. And what they found was that if you brushed your teeth soon after, there was still detectable peanut. If you did mouthwash soon after, there was still detectable peanut. But if you waited several hours later, ate a peanut-free meal, and then tested, then it was undetectable. And so that's something just to be thinking about. Now, in the case of our little ones, where they may be at a gathering with tons of other little kids, who then somebody has Sophie the giraffe. It's been in somebody's mouth, and now your kid picks it up and now sucks on Sophie's head. Then these are going to be things to just be thinking about. So in the context of the little kids. And so it's a little harder with the babies and the toddlers who are kind of sharing things and putting them in their mouth. And thinking about how to clean between those is going to be something worth doing. Also thinking about pets. This is something that sometimes goes under the radar, but let's say pet food, and 40% of dog food can have egg in it. So let's say there's a kid or a dog that's eating food and then smooches a kid, then they may expose that child to allergen that the dog is eating. And in some of the young kids, they may eat the dog food too. So you'll want to be thinking about that. So proper cleaning is easy. So soap and water, wet wipes work. Hand sanitizing gel alone is going to desiccate and dry. It's not going to take care of moving the allergens. So you want to mechanically move the allergen from the hands. Same with surface. So soap and water, commercial cleaners, commercial wipes work. You don't need bleach. You don't need Lysol. You don't need a blowtorch. It's pretty simple cleaning that's going to work. Now, when we're thinking about the kids and thinking about issues with cross contact, we're going to want to be thinking about their different developmental levels. As we talked about, the little kids are exploring their environment with their hands in their mouths, and the big kids are exploring each other with their hands in their mouths. So we're going to have different cross contact issues to be thinking about. And ultimately, being able to modify how we teach and how we coordinate and advocate based on their developmental level is going to be where it's the trickiest and the most useful. So as far as communicating, as the kids get older, they'll need to know about their allergy. And with anybody who's going to be responsible for caring for our kids, whether they're serving and preparing food, whether they're going to be just with them and the only grown up, they'll need to know how to prevent allergic reactions, and they'll need to know how to deal with emergency situations. Now, as far as teaching, as I was getting at, we want to teach our children. We want to teach our relatives. We want to teach others who are going to be caring for our kids. And then ultimately, we're going to want our kids, when they start getting older, to be able to learn themselves and teach others and explain to others about their food allergy. So a couple things that are worth talking about are that I have 3 points to make. The first is the unknown can be scary. So kids can come up with their own answers that are way scarier than reality, right? So we know what's under the bed, nothing. But when it's dark and the kid's mind is going, it could be really scary. Kids believe us. They believe grown-ups. Awesome examples are Santa Claus, where this guy flies across the world in a single night, dragged by 9 or more flying reindeer. And the tooth fairy doesn't even need reindeer to do it, and she doesn't get a break. It's like day after day after day. So they believe us. Now, the third point is that with food allergies, as you've seen, comes uncertainty. And so if we fill the uncertainty with misinformation, it could be terrifying. So we want to be very aware of the powerful messages that we don't want our kids to necessarily be seeing. We ourselves want to be able to debunk them because it really doesn't have to be as scary as it sometimes seems. And this is where teaching is so important. So having age-appropriate allergy management skills for kids to give them a sense of control, developing routines and games. I think all of your children are so young that they wouldn't necessarily be at this level yet. This is more about you guys teaching your backup caregivers so you can get a break. And so you can have a community that understands and helps work with you. But as the kids start getting older, in kindergarten, understanding what it is that grownups are doing, or I should even say like 3-year-olds, 4-year-olds, understanding that you get a grown-up when you want to know if something's safe to eat. And then as the kids get older, start understanding that labels are how a grown-up knows. And then once a kid starts being able to read, then them participating and practicing, but doing it very, very slowly without giving the responsibility. Being able to then practice scenarios with bigger kids, like a middle schooler who's going to be going to a party where there might be pizza and they're allergic to dairy, and going through some of decision making that the kid might do on their own. Preparing for new situations or places, like the beginning of a new school year, going into the school and being able to explore and talk to the cafeteria team and talk to the school nurse. These would all be awesome things to do with kids. And then teaching assertive skills, being able to say no thank you when somebody offers them a cookie, so they don't have to worry about hurting someone else's feelings and just feel confident enough to say, I don't know what's in there. No thank you. Now, I like to approach it like safety rules. You get in a car, you put on your seatbelt. You get on wheels, you put on your helmet. You'd never dive in the shallow end. You look both ways before you cross the street. You make sure that a grown-up in the know has read a label and gives you the clearance to eat a food. You don't eat a food that doesn't have a label. You know that emergency medication is somewhere nearby. You know how to get a grown-up if you made a mistake or if you're experiencing reactions. You wash your hands before you eat food or put your hands in your mouth, eyes, or nose. You don't eat other people's food. Now, sometimes mistakes are made, and that's why we have epinephrine. That's why we have emergency preparedness. So that's why we're ready to react, to recognize an allergic reaction that requires epi, to give epi, and then to activate emergency response. We mentioned this before, recognizing anaphylaxis. It's easy to recognize anaphylaxis if symptoms are in more than one system. I got at this before, right? We have skin, derm, respiratory, GI, cardiovascular, and neurological, and these kind of come together a bit. But if a kid even has mild symptoms, let's say a couple local hives around the mouth, and now they had a little vomit, and now they sneezed 5 times, that's more than one system, even though those are mild symptoms, and treating with epi and shutting things down would be the right thing to do. And so you can imagine how many different combinations of things can kind of come out of what I was saying, where each kid can have a different reaction from another kid, and each reaction can be different from one time to the next. And that is why we have these things called action plans. So I am hoping that your allergists or your primary care clinicians have given you an food allergy and anaphylaxis emergency care plan. And now what this should do is be a nice cheat sheet that you can look at and guide when you want to treat with epi. one of the things to think about here is that after thinking about this stuff, after being here, after talking to your own allergist, many of you would be able to do this without relying on this. But this is going to be really important when you teach others. So when you pass off your children with other people, you'll want to give them this in advance. You'll want some time to chill out. You might want to show them this video, which we're videoing, so they can look at it, and then you also can go through it. And what this does is delineates when you would treat with epinephrine. So this particular action plan, and our team has modified this action plan to use when we give it to families when they're newly diagnosed. So this is the American Academy of Pediatrics plan. And the reason we like using it is because it was put together to be able to be used by school nurses, pediatricians, and allergy teams, and pretty much agreed upon for which signs and symptoms would trigger the use of epinephrine. One of the things to think about, though, is that by being a little bit earlier to treat with epi, you will not be wrong. So you don't need to hold back, especially if a child is having a reaction that comes on quickly or if you're uncomfortable. But we'll talk a little bit about when you'll be comfortable to sit and watch. And it wouldn't be multi-system, and it might be a couple of hives around someone's mouth. And we'll talk a little bit more. All right, so for severe allergy, this is what you're going to want to give epinephrine for. So if any of the following symptoms, even if it's only one system, these potentially severe symptoms would be what we would treat with epi, especially after eating a food that has allergen in it or may have allergen in it. Shortness of breath, wheezing, coughing. In the little kids who can't tell us that they're short of breath, I mentioned it before, we might see nasal flaring, we might see tugging above their sternum, tugging in their ribs, belly breathing. We might see, as I said, coughing and wheezing, which we'll see in the little ones as well. Skin color being very pale, bluish color, grayish color. These can be changes that could tell us that somebody might be having cardiovascular symptoms, and where in a weak pulse that might be something described in an older person. In a young baby, a fast heartbeat would be something that somebody who was able to get that, like a primary care doctor or the emergency department, might be able to get. Fainting and dizziness in a little kid, we're not going to hear them tell us that they're dizzy, but we might see a kid wobbly in appearance. We might see them lose consciousness and other mental status change that we'll talk about in a bit. Bigger kids might describe tightness or hoarseness of the throat. A baby might have a hoarse cry. We might see drooling, trouble breathing or swallowing. Again, those retractions we talked about, and drooling, swelling of the lips or tongue that can bother breathing, vomiting or diarrhea, if severe or combined with other symptoms, many hives or redness all over the body, feeling of doom, confusion, altered consciousness or agitation. In the kid, we might see lethargy, very, very tired, not expected. We might see inconsolability, just can't calm them down, even if you're giving them exactly what they want. Now, the mild reactions that wouldn't necessarily trigger the need for epi, if a kid has one of them, let's say a few hives after eating a food, or sneezes 5 or 6 times, or tummy ache. And in the case of the young ones, we might see like a little spit up. We might see knees to chest. We might see back arching. Those alone then following your action plan and doing the plan that your pediatrician works with you is what you would do. But if these were in combination and they were more than one system, then this is where many of us would recommend go ahead and get control with epinephrine. And I was mentioning before using behavior as a way to give us some reassurance. So if a kid can play, if you're holding up Elmo and they're watching Elmo and they're giggling and they're happy, then that really can be a very reassuring thing. If you're giving them exactly what they wanted, normally they'd be really into it, and they just are just going bonkers and they're just so upset and they can't turn around. They have a couple of hives and they're acting really weird. Then that would be a really good reason to go ahead and give them epi. Some of the bigger kids can say weird stuff. My kid said that he couldn't get the taste out. Some kids might describe an elephant on their chest or a frog in their mouth. So now, I like to think about anaphylaxis and water damage. The sooner you take care of it, the easier it is to take care of. So the longer anaphylaxis remains untreated, the more end organ effects occur and treatment becomes more difficult and someone just feels worse. And so I like to tell people that it'll make you feel better fast. And so epinephrine is first-line treatment of anaphylaxis. Delays are associated with increased bad things, also hospitalizations and the chance of having a second phase. So the sooner somebody treats, then the quicker the reaction can resolve. So currently there's a bunch of different devices. Now, for the younger kids, so IM, intramuscular epinephrine, is what's available for the younger kids. Recently, a nasal epinephrine has gotten FDA approval. This is by Neffy, and what this indication is for 33 pounds and up in a kid who is 4 years old or older. So all the younger kids are still intramuscular now, and there are studies to look at the efficacy of this and the safety of this in the younger age group. But for now, intramuscular epinephrine is the way to go. And your allergist or your primary care clinician will have prescribed you your epinephrine. And we have training devices. So I'll go through that when we're done with this with you guys. And then also make sure you have your own training devices to use to train others. So common side effects, paleness, shakiness in some of the older children, that it's expected that the epinephrine may interact with receptors on skeletal muscle and cause shaking. And I like it because we know it's working. And so being able to give people a heads up about that that's normal and that's not bad and that's not something to worry about is nice to talk about. In the case of a kid who has a fast heartbeat because of their allergic reaction, giving epi actually may decrease it in a good way. But then in the kids who have things that aren't cardiovascular that are happening, it may also, as an expectation, increase heart rate a bit. Some people can have headache and nausea also associated with epinephrine. About 10 to 20% of kids might need a second dose. It's good to have 2 available. Sometimes we may put off the first one in our hand, and therefore having the second one to put in our child is a good thing to do. In the case of the intranasal for the older children, there's also the recommendation to have 2. And in the case that the first one doesn't work, then giving the second one is something that you would want to do. When giving it to the youngest kids, it's easy to just drop their pants and then you have the thigh very easy to get to. In an older person, we wouldn't want somebody to feel like they need to get privacy. We don't want them to have to get up and move. So we're going to want to just be able to treat them and to kind of keep them from raising to a standing position. And so it is designed to go through one layer of thin clothing, the intramuscular version, but we're going to want to be careful of things like cell phones and cargo pants because it may not make it through those. And we're going to want to be prepared for the fearful child and the older kids, but in our younger kids, we're going to want to teach people and ourselves be ready to know how to hold and how to administer it. So having the trainers is going to be really important, and you're going to want to be able to train your babysitters and whoever it is who's going to be caring for your child. So afterwards, I'll go through all of them with you guys, but just for now, just as most of us have the young ones, one thing you're going to want to be thinking about is teaching the people who are taking care of them. If you guys are alone, how are you going to hold them so their hand doesn't come in their way? Because one of the things that you can do is decrease the chance that they might have a laceration. And so what I recommend to people, and the easiest, is to find a flat surface. The floor is fine. But in the case here, I'm going to make an air baby. So here's the baby's head, arms, waist, legs. Do you see the air baby? I'm a righty, so I'm holding the epinephrine device in my right hand. Now, with my left now, the baby's head is behind me, or the toddler. Their thighs are right here. So now I'm able to immobilize their thigh and put the device in their thigh muscle. Now, in the case of intramuscular, the reason we're using the thigh muscle is because it's well vascularized. And that means that blood is flowing through quickly, and you get to peak levels of epinephrine in about 8 minutes. Now, the intranasal one that's coming, that also has peak levels very quickly as well. And so that's where epinephrine is an excellent medicine, because it works quickly, and it works quickly everywhere where we want it to work. Now, you're going to want to have it available with you. Diaper bags are a great place to carry it. Avoid extreme temperatures. And so, like, for example, if you were skiing, you'll want to put it within your jacket where your body heat can keep the device from freezing. If you're out at the beach, you'll want to keep it from sitting on the hot beach towel where it's just baking in the sun. Again, keeping it on your body. So if you are comfortable, then chances are it's not too extreme, the deviation. A couple of myths worth debunking is some people in the past have said, give an antihistamine first. That is a dangerous myth. Antihistamines are comfort medicine. And some antihistamines like diphenhydramine, Benadryl, they can make a kid sleepy. And now how do you assess their mental status? How do you use their behavior if they're snoozing? And so these are things to be thinking about. Now, epinephrine is the treatment of choice for anaphylaxis. And the special thing about epinephrine is that those mast cells and the basophils that I was telling you about, that epinephrine works on their receptors to stabilize the cell membranes of these things, to make it less likely that they'll degranulate and lose what's inside. So epinephrine not only works at all the end organs where we want it to, but at the heart, the lungs, the blood vessels, it's also working on the allergy cells themselves. It's also a myth that we're calling an ambulance because we've used epi. We're calling an ambulance because this may be a serious allergic reaction. It might need more than just that first dose of epinephrine. And so the sooner you give epinephrine, the less likely you actually need what the ambulance is bringing. So that ambulance is bringing backup in case that first epinephrine doesn't work. So we're not calling an ambulance because we used epi. We're calling an ambulance because we had a reaction that may quickly progress, and we want to make sure that we got it under control. Now, you'll talk to your allergists about whether or not you'll be calling an ambulance when your child experiences an allergic reaction, even after you use epi. Some people are saying maybe you don't need to call an ambulance anymore. We're saying that if you had 2 doses available, if you immediately get control, if the symptoms were mild in the first place, then it goes away and doesn't come back. That might be a kid who doesn't need to be observed in the hospital. And that'll be something that you'll want to establish. What are those rules and parameters with your primary care clinician or your allergist? The other myth for the case of the intramuscular is that the needle is huge. If you ask a little kid how long they think the needle is, many of them will think it's the length of the device. I would cry if it was that long. It's much, much shorter. So in the case of the adult dose, it's 3/4 of an inch. In the case of the pediatric dose, it's 1/2 of an inch. And in both cases, it's less than the length of a dime. So epinephrine, first line treatment of choice. It acts where we need it to. It'll make you feel better fast. It's fast acting, delays in administration, increase bad things. Err on the side of caution and give it if you have any doubt. You'll shut it down, and it's a safe medicine. So those are the pillars of food allergy management, and you'll want to take them with you wherever you go. Home, school, restaurants, parties, play dates with other caregivers. And thank you very much.